Hello, everyone, and welcome back. I'm Kelly Lenvoy, providing you another special episode of Arthritis Consumer Experts #CR Arthritis series from the Canadian Rheumatology Association's annual scientific meeting this year in Calgary. Today, I'm very pleased to welcome as our guest Shawn Brady, the Vice President of Arthritis Rehabilitation and Education Program and Innovation at Arthritis Society Canada. Welcome to the show, Shawn.
Thanks, Kelly. It's really great to be here. Looking forward to our chat.
So, Shawn, you're presenting at the meeting at a session titled Closing the Gap Between Primary Care and Rheumatology, the Rheumatology Rapid Assessment Clinical Model. And I think for our audience, just to provide a bit of a context, they've heard ACE talk a lot about how wait times are significantly increasing in accessing specialty care like rheumatology across the country, in particular in remote or underserved communities. Your model of care sounds like this could be a potential solution to close that gap and help patients get faster access to care. Can you tell us a little bit about the model?
Sure. So the model is probably in parallel and similar to perhaps what some people on watching this video would have been familiar with rapid assessment clinics that have been developed in Canada around surgeries. So often now, I think in most provinces, if you need to have a knee replacement or a hip replacement, you're often put into a sort of a triage system called a rapid assessment or rapid access clinic, where you are assessed and then provided with a pathway to get to surgery earlier or other supports. This kind of model, the rapid assessment clinic model, does not currently consistently exist with rheumatology. So, as we know, and as many of you know, watching, the wait time to get into primary care to see your primary care physician, if you have one, can be a barrier. And then once you potentially do have a working diagnosis of an arthritic condition, the wait time to get from your primary care and your family doctor to a specialist in rheumatology can be years. It can be months. It can be, many months depending on where you live. So the idea of the rapid assessment clinic model for rheumatology is to utilize clinicians that are non-physicians. So we have in Canada a program and an education program called Advanced Clinician and Practitioner in Arthritis Care. And that enables occupational therapists and physiotherapists specifically to get extra training so that they can actually support patients in advance of going to rheumatology so that they can help basically be a gatekeeper in terms of getting people quicker access. What they do essentially is look at an individual's condition and determine, is rheumatology the answer? And if it is, they can make that referral and get you quicker access. If rheumatology maybe isn't the answer, if it is more of an osteoarthritis where maybe a surgical consult is more appropriate, they have the skill and knowledge to do that. Also, if maybe a more conservative model of care, like a rehabilitation program, is more appropriate, they can then divert to there. So essentially, by utilizing and expanding the clinicians we use, we're very dependent on physicians in our system. We love physicians, they're fantastic. We don't have enough of them, and there's no miracle that's going to save that and help that. So, this is an innovative system change where we're utilizing full scope of other professions, OT, PT, to get individuals faster access.
So where's this model currently being deployed? Is it across several provinces or just in one province? Where is this occurring right now?
So it's probably occurring in different pockets. It's not a consistently accepted model yet. In Ontario, that I can speak specifically to because the program I lead is publicly funded through Ontario Health.
Sure.
It's our arthritis rehab program. We have started to develop it in key geographies. So we have about 4 or 5 of these rapid access clinics operating. They all started with an occupational therapist by the name of Jocelyn Murdoch, who works with our team. She's been a long-standing champion and very much a pioneer of this work. and she works in a remote area in Sudbury, Ontario, but serving other remote northern communities and Indigenous communities. And what she has done is really built relationships with Indigenous communities, with primary care physicians, and with rheumatologists to make this model work. That's kind of been the template. And now I know the Ontario Rheumatology Association has done a lot of great work to adopt this model and expand it to Thunder Bay, Timmins, Sault Ste. Marie, North Bay within Ontario. We are presenting at CRA, which is part of why we're chatting today, in the hopes that we start to ignite some thought leaders in arthritis care to look to adopting these models more broadly in other provinces where they don't really exist in the same way. So I would say Ontario is very much the leader in this right now, but we really want to try to look at anything we can do to influence and look at these models in other provinces, especially, across Canada is so vast and those areas of inequity are very much outside Ontario. They're very much in, rural Alberta and BC and Manitoba across the board.
Really, really interesting. And maybe just to follow up, there are a couple of points there that I want to focus on. First of all, we're talking about how this is such an important model to address disparities in care for remote patient populations and also for patient populations that face health inequities. I'm just wondering if you can spell out a little more clearly how can we help those two different patient populations get access to better and more equitable care?
So you're speaking of, sorry, remote. So the two are remote and you said two populations, remote
Oh,
and
and ones that are experiencing, discrimination because of culture or
okay.
ethnicity. Yeah.
Yeah, equity deserving groups. Yeah, so there's definitely with this model, I think a lot of what we're doing in Ontario is prioritizing those equity deserving populations and communities. Specifically for the exact reasons you describe is research and data would tell you that where you live in Canada does dictate how long it takes to get service. And that's not acceptable, I think, for many of us who work in healthcare and as a culture and in a proud Canadian culture with our universal system in general we really need to do better for those communities. This model really does, I think we really want to magnify it in those communities specifically, recognizing again, there aren't as many physicians, as many practitioners, but if we expand that scope and actually think of this model in a different way and think of how to access rheumatology in a different way, we can make some headway and make some gains and get people care sooner. Getting right back to hard numbers, if you look at wait times across Canada in remote communities versus urban and the number of rheumatologists working per 100,000 people, in, let's say, Toronto versus Thunder Bay. I know those stats specifically because the ORA have done a great job in quantifying this. So I believe in Toronto, and I don't have the exact stats, but this is more to share the spirit of this. In
Sure.
Toronto, there's maybe one rheumatologist for 70,000 patients, 70,000 people. In Thunder Bay, there's like 1/10 of that. So you can imagine your wait times would be, 10 times longer. The amount of care you'll get is 1/10. So that's why I think the focus really is these communities, is to get more advanced practitioners supporting rheumatologists and getting faster access to care in those remote inequity deserving groups.
For our viewing and listening audience, we will provide links at the end of this episode, not only to your presentation, Shawn, but to some of that programming you're talking about that the ORA has established for Northern Ontario, and also links to a couple of national surveys that ACE has conducted, one in particular on health inequities and arthritis in Canada, to give some sort of further background and color for our audience. Finally, Shawn, I just want to go back. We're hoping to see and obviously congratulate you on the work that's being done in Ontario. We hope to see this spread across Canada. I'm wondering if you have any recommendations, any lessons learned for providers or patients in other provinces or territories who may be considering and implementing a similar advanced practice model.
Yeah, I'm glad you asked that question because that's precisely why we're presenting at the Canadian Rheumatology Association conference, is to influence other provinces and other individuals who might feel stuck or challenged by this, and even patients. So I think part of this is innovation in health system. So with any innovation, there needs to be an open mind on all parties. So again, an open mind to the fact that maybe a physician always isn't the answer, on both sides, from physicians and from patients. And I share this because data would show that when an advanced practice clinician sees a patient with an inflammatory arthritis, they miss 0% of the time. There's a lot of research to substantiate an advanced practice clinician can detect an inflammatory condition with that amount of accuracy. So we know that this can work. So there needs to be, I think, an open adoption and open mind from clinicians and from patients that this model can work. Then I think it's a matter of, again, recognizing maybe these advanced practice clinicians don't exist in these communities, but there are stepping stones. There are ways to build relationships with your primary care providers, looking at maybe getting, having your physiotherapists and occupational therapists who work in those areas and maybe in primary care to maybe get a bit of extra training with arthritis specialty, so that they can identify and start to maybe work towards this model. And then ultimately, patient advocacy is huge. I mean, these are big shifts. They're government changes. We do have a really great advocacy team, and I know a lot of the work ACE does as well, from an advocacy perspective, is instrumental in going to government. Government is thirsty for innovative models. They recognize the physician crisis is real. So this is good timing to really implement other models of care that aren't so physician dependent and that can actually broaden the scope of other practitioners to help solve this problem. So I think there needs to be openness, there needs to be some energy behind it, some advocacy, and some as well some appetite for imperfection. I think in healthcare we always want that perfect solution, and I think we know that that doesn't exist. So it's being comfortable with imperfection, but at least moving the ball forward and really trying things, trying to build relationships between primary care and rheumatologists, building those pathways, really promoting the use of, again, other clinicians outside of physicians to help do some of this work as well.
It's a fantastic wrap up. And once again, congratulations. I mean, really exciting information to be sharing with providers and patients across Canada that here's a real solution, advanced practice models that work and that we hope to see adopted across the country with your leadership, Shawn. Thanks very much for joining us today.
No, thank you, Kelly. Thank you, Ace, and thank you all for watching. And I'm sure materials will be shared and emails as well. If there's any follow-up questions, happy to support that as well.
Absolutely. Yes, and thanks to everyone out there watching. We hope you can join us for our next episode of hashtag CR Arthritis as ACE shares more exciting science and innovation from the CRA's annual scientific meeting. Bye for now.